So next we have a video presentation on incisions of parotidectomy by Dr. Kaustubh Patel sir. Sir is the Director and Senior Consultant Head and Neck and Robotic Surgeon, Surgical Oncologist at HCG Asta Cancer Center, Ahmedabad. Sir.
So it's not a video, it's just a presentation just to begin, and Daksha has shown a very good way to put a modified Blair incision. The first parotid surgery for tumor was done in 1823. The Blair in 1992 described the curved cervicomastoid. 1892 described the curved cervicomastoid facial incision, which is a lazy S, which we all follow now. And then there was a modification by Bailey in 1942. Edson et al. Described Y incision for malignancy, and Appiani started the facelift incision for parotid. These are our key concerns: exposure, adequate access with no compromise in extent of removal of targeted, extent of resection, which is important. From total parotidectomy to adequate parotidectomy or radical parotidectomy, the exposure has to be perfect, because parotid tumor, if it recurs, it's a nightmare. So that's the reason why during your resection, the exposure has to be perfect. We want to reduce the complications like injury to important structures like facial nerve, which is extremely important, and that's why your incision should be adequately put so that you can preserve the nerve comfortably. And of course, last but not the least is the cosmesis, concern for cosmesis. And these are all the types of surgeries for parotid tumors. And these are the types of incisions which I described. But the most common one is a modified Blair incision, which we do. And then there are some more modifications also which are described. I would say, how many of you put other incision than modified Blair? So Deepak and Ravi and KK
occasionally.
and Poonam, yeah. So that's what, I think we can have a discussion in which case, Ravi, you would put a different incision.
Initially when I started the facelift, dictum was this, that tumor must be benign 100%, because you should not need to go into the neck. You should be posteriorly, so that you don't have to go too much anteriorly. But as I am now getting more and more familiar with cervicomastoid, I have realized that you can extend the indication of this incision. But where you are committed that you are dealing with a malignant tumor and it is not posterior, it is in the main body, rather anterior, and you are committed to do selective neck, I think in that situation you must use modified Blair, because it will give you the access. The only complication of cervicomastoid incision is it invariably gets keloids, invariably, irrespective of the race, irrespective of the color. I think the tension line when your neck moves is directly on that incision, and it is that modified Blair heals very beautifully. The only thing is this, that this, howsoever badly healed scar, it is not seen. And therefore, what is not seen, you are not bothered. Under the cloth, whatever is there, under the hair, you are not bothered. But that incision technically heals badly. Modified Blair technically heals much better, gives access to the neck much better, and therefore, you must use the judgment where you are wanting to use these. I saw just 15 days ago one patient operated by me. She had come to me with something else. I could not even realize where the incision was, because it was cervical mastoid. So it's a give and take. You should judge according to the patient and your need.
Poonam, then KK, and then Ravi, then Deepak.
Sir,
Deepak behind, somebody can pass the mic to Deepak.
Sir, I agree with sir. So almost similar incision I also take. So slowly I have realized over the years that rather than taking it on the mastoid, I have started doing it like the iliaceus. So making it more anteriorly. So naturally that part of the skin which has the chance of getting necrosis, other than that having the higher chance of keloid. It really does help. Other than that, sir, taking it much bigger incision onto the preauricular the crease, I have started taking it from the level of tragus usually and taking it down. So it usually decreases the size of the incision a lot. Many times for small incisions, I have tried to take the mini incision, which is the U incision, not very frequently, but once in a while we can do it if it is a superficial tumor and it is a small one. So
Yeah.
that's the way I do it.
We will come to that. KK?
Sir, in an occasional young female patients, I may do a facelift sort of incision going behind the ear and along the hairline.
Yeah.
So that's
Deepak?
It has to be a pure infraauricular lesion. You shouldn't be expected to do a lot of facial nerve dissection because it's not possible. So your dissection stops at the main trunk and then you'll be able to deliver the specimen. And I don't usually do the full facelift, I do the modified facelift where you don't take it to the hairline.
Yeah.
Because at the hairline, if you have scar alopecia, it looks really bad on the patient. So infraauricular tumors where you don't need to dissect the facial nerve much, I would do a modified facelift.
Thank you. And there are some data, but these are not level 1 data. So most of them are out of experience. And you can see the different incisions which are tried. So what I do is I divide according to the location of the tumor. The horizontal line is from the external auditory canal going further to the midline of the nose, and the vertical line is the sigmoid notch going down. If the tumor is in the lower zone posteriorly, then you can have the smaller incisions and do the dissection. If it is in the upper part posteriorly, then you need to take your incision above the tragus. As Poonam said, she stops at tragus, she doesn't go above that. So you can stop at even the ear lobule when the tumor is in the lower zone. If it is in the upper zone, you need to take your incision up. The anterior tumors requires an excellent exposure. So that's the reason why you need to put a bigger incision. If there is a very small tumor anteriorly, then there is a special approach which we do at our place now, and that I'll elaborate later. So this is what I'm talking about. Poonam, when you say that you stop at tragus, I would urge you that next patient you try to stop a little below, then a little below, then a little below, and you will be able to do it, and you don't need to extend the anterior incision. In this time of good retractions and good magnifications, you should be able to do these tumors. You can remove even the superficial and deep lobe, and this, with this incision you can see all the nerves including the greater auricular nerve. So you just have to lift. What you do is you dissect around the external auditory canal from postero-inferior side, and then elevate the flap, taking the skin hooks on the ear lobule as well as your upper anterior flap, and raise the flap, and then you will have an adequate access to this area like this. We have done a total parotidectomy with this incision. And you can see how it heals, and there is no incision in the front of the ear. We usually put the flat drains posteriorly in the hairline, so that it is not. This is another case where you can again see that there can be a good exposure, and this is the specimen. Another case, again good exposure, specimen. Now this patient had a tumor in the anterior zone. So this anterior zone tumor, this was one of our first case of intraoral excision. This was the tumor. Extremely anterior. You can see the distance from the ear external auditory canal. This was an accessory gland tumor near the parotid duct. So we went intraorally, and we could do this with neuromonitoring, so that we are very sure about the buccal branch and the ophthalmic division branch. And we could remove this specimen. This is after about 2 years. This was a benign tumor, pleomorphic adenoma. You can see the scar intraorally, and you can see all the movements well. The caveat is you need good mouth opening, and you need anterior zone tumors, not lower zone, anterior zone tumors. You can't go beyond masseter intraorally and resect the tumor. There the exposure and the delineation of the nerve branches will be a difficult thing. This is a good article for the students to go through. Thank you so much.
Also from
Yeah.
intraoral route, from where do you start? From the duct opening or from?
From the duct opening. From the duct opening, you always ligate that part and then try to dissect. You find the upper buccal branch first, press it, then go ahead, and from below, from the buccal fat pad area, you start dissecting. You will hit the anterior border of masseter muscle. From there, you start defining things, and with neuromonitoring, you will be able to at least not cut the important nerve.
Also, 2 quick questions. Nice presentation, and I marvel at everybody doing different incisions. All you do is a smaller incision,
Yeah.
the one that you showed. I think we need a little more robust data that it gives patients more satisfaction than what we do. Because in my experience, the problem is never on the vertical limb scar. That heals very well, you hardly see it. It's the curves that cause problem. Ravi, I'm trying to talk like you. The curves that cause problems. You know, that's the problem. That's, अरे you autobahn बोलता है, you are अच्छा wait, these people don't know. I want to tell one more thing. So we must have some data that yes, my patients are happier than what Ravi and me did, then we'll change our practice.
No, I don't want you to change. I want you to think, explore, because these are the channels where you will never find randomized trial. You will not find those kind of things. You will have to learn yourself.
We are urging the youngsters to have little more robust data before we do it. Facelift is a good approach. And the second about the intraoral, it's conceptually attractive, but the specimen that I saw and the way you take it out, it's like an enucleation. So you must have margins. Pleomorphic is a lethal disease to have recurrences. And then if they come, maybe he didn't have, we've squeaked through lucky, but you should You should have good margins. It will
Can
be
you
very select
project
patients.
my presentation?
I would be scared to do an intraoral.
No, I was also scared, but this was the first patient was very insistent, I don't want any scar. I thought that this is probably the right case for me to begin with.
To be honest with you, I've also done a couple, but I'm scared.
So, if you see this tumor, it's not really lobulated. Can you see this? It's very well circumscribed.
We are not challenging or debating or pointing it out, but for the younger audience,
This is not
what they
to
told you
venture.
is very important. Nobody is bothered about preauricular segment of the incision. It is never seen. It gets concealed in the natural crease, number one. Number two, all incisions healed side to side, not end to end. 1 centimeter, 1 millimeter, 1 feet, 1 meter, all incisions will heal the same way because they heal side to side. And the most important to speak like me is, bigger the surgeon, bigger the incision.
Start with, if you are doing your first 50 or 25, start with the standard incision. Then try to modify things, because you have to play, in Aditya Joshipura's language, you have to play Ranji and first class cricket in order to start playing in test cricket.
So I just have one comment in lines with what Dicruz has said. Of course, this was not in salivary gland, but in thyroid cancers, what we did was we assessed the patient's satisfaction of the thyroid scar. And what we found was the patient themselves rated their scar using a questionnaire which is standard for rating the scar, the patient-specific scar assessment. And then 2 surgeons did it separately. And that is for thyroid, when we do the thyroidectomy. So what we found was the patient satisfaction was much more than the surgeon's satisfaction. The surgeons were less satisfied compared to the patient. So what we essentially did, what I'm trying to say is the patient's concern of scar is lesser compared to surgeons, as long as we can do a decent job. So what we can do is probably take subcuticular incisions, avoid cross-hatching, handle the skin better. So all that also will help in the wound healing and prevent an hypertrophic scar. That's the point.
Yeah, Poonam.
Sir, coming to like the point which Shiva said, coming to the next level. So in fact in TMH we have done a small study about the shame and stigma, because here ultimately we are talking about the patients, what they feel about the incision. And we have in fact done this study, I have done. So we have this shame and stigma questionnaire which we have validated in Hindi and Marathi. And then we looked into the patients where they had big defects in the face. And we are in the process of publishing it, and we have seen that in fact those patients also, they hardly have these feelings, especially our Indian patients when we compare them to the Western world. So in the same vein with Shiva and Dicruz sir, probably these incisions may not make that much of difference if they are healing well. But having said that, it is always better to have a small incision, as you said, as your experience increases, but then that is open for debate.
Dr. Kaustubh, one last question to you.
Last question.
Is, do you have you ever done those incisions where they make the incision right on the tragus and then you...
Yeah, doctor, after talking to Dr. Jatin Shah, I started doing it for a few cases and then I have stopped doing it. The reason is that skin is very thin. It becomes very difficult. I don't know, Anil, you have any experience of doing that? So, Abhishek.
I think the ground rule there is if the preauricular skin crease is very well defined, which happens in elderly and some with fat faces, then you go in the preauricular skin crease. Otherwise, you can go bang on the tragus, elevated with a knife or a periosteum elevator, and that heals in the natural shadow line of the face. But most of our patients have a very well defined preauricular skin crease and we can put the incision.
Yeah. So the question was you put that or not, but the skin is very thin. I'm really afraid, and the first patient had a blackening of the tip and then the scar was really bad. So then I thought that. Yeah.
we feel conceptually that taking a smaller incision will give a smaller scar, and it happens in thyroid as well. You take a small incision and you pull, and you keep pulling and you keep retracting, and at the end of surgery the edges are slightly dusky, and when you suture that together, that's what gives you a bad scar. So I totally agree with Ravi. Take a scar that's comfortable with you, don't pull. I've seen guys doing through a small horizontal incision supraomohyoid, and guys coming back with submental recurrences. They can't clear it.
No, the first...
You don't curve, but make an incision that you are adequate with.
Anil, the first slide, if you remember, was exposure.
Yeah.
That is extremely important in any surgery. You must have, you can do minimal invasive, but your exposure has to be perfect. Thank you.